Examination of the cranial nerves gives us a way to look at the brainstem, all the way from its most rostral extent to its most caudal extent. If we look at an enlarged model of the brainstem, we realize that there are actually two cranial nerves that are tracts of the brain that are just at the top of the brainstem, cranial nerves number 1 and 2. And then for the three main divisions of the brainstem, the midbrain, the pons, and the medulla, we can divide the cranial nerves into each one of these three sections. Cranial nerve number 3 and 4 are in the midbrain. Cranial nerves number 5 through 8 are in the pons, and 9 through 12 are in the medulla. So the cranial nerves can be divided into 2 for the midbrain, 4 for the pons, and 4 for the medulla. The second anatomical point that's important to remember is that for all the cranial nerves, except for one minor exception that we're not going to focus on, the clinical findings are on the same side as the involved cranial nerve in its nucleus. The last point that we need to keep in mind is that these cranial nerves again give us valuable Y levels on the vertical axis of where we may be in the brainstem. And that combined with long track findings from those descending and ascending tracts are powerful in localizing brainstem lesions or brainstem pathology. So let's look at these cranial nerves in a little bit more detail. Cranial nerve number 1. Olfaction is the only sensory modality with direct access to the cerebral cortex without going through the thalamus. The olfactory tracts project mainly to the uncus of the temporal lobe. Cranial nerve number 2. This cranial nerve has important localizing value because of its x-axis course from the eye to the occipital cortex. Lesions of this cranial nerve are identified by directly viewing the nerve head by using an ophthalmoscope, as well as by testing visual acuity and testing visual fields. The pattern of visual field deficit indicates whether an anatomical lesion is pre- or post-chiasmal, optic tract, optic radiation, or the calcarine cortex. Cranial nerve number 3 and 4. The third nerve in particular can give important anatomical localization because it exits the midbrain just medial to the cerebral peduncles. So compression of this area by a mass would give a third nerve palsy plus a contralateral hemiparesis. The third nerve controls eye adduction, medial rectus, elevation, superior rectus, depression, inferior rectus, elevation of the eyelid, the levator palpebrae superioris, and parasympathetics of the pupil. A third nerve lesion would result in the eye being turned out and slightly down, with ptosis and a mydriatic pupil. The fourth nerve supplies the superior oblique muscle, which is important in looking down and in towards the midline. A lesion of this nerve would cause the eye to be slightly up and out, and the patient will tilt their head toward the opposite shoulder to minimize the diplopia. Cranial nerves 5, 6, 7, and 8 are located in the pons and give us a view of this level of the brainstem. Cranial nerve 6. This cranial nerve innervates the lateral rectus for eye abduction, so a lesion of the sixth nerve would result in the eye being turned in. Remember that cranial nerves 3, 4, and 6 must work in concert for conjugate eye movements. If they don't work in concert, then diplopia results. The medial longitudinal fasciculus runs from the sixth nerve nucleus to the third nerve nucleus for conjugate eye movement. Eye movements are controlled by 4 major ocular motor gaze systems, which are tested for on the neurological examination. They're briefly outlined here. Number 1, saccadic eye movements. These are connections from the frontal gaze center to the pontine paramedian reticular formation. Saccadic eye movements are important for rapid eye movements to bring new objects that are desired to be viewed onto the fovea. Number 2, smooth pursuit movements. These are connections from the parietal occipital gaze center via the cerebellar and vestibular pathways. Smooth pursuit is important for eye movements to keep the moving image centered on the fovea. Number 3, vestibulo-ocular movements. These are connections from the vestibular system to the nuclei for motor movements. The vestibulo-ocular keeps the image steady on the fovea during head movements. Number 4, vergence. These are optic pathways to the oculomotor nuclei. Vergence movements are important to keep the image on the fovea, predominantly when the viewed object is moved near. The near triad consists of convergence, accommodation, and pupillary constriction. Cranial nerve number 5. The entry zone for this cranial nerve is at the mid-pons with the motor and main sensory, for discriminatory touch, nucleus located at that same level. The axons for the descending tract of the fifth nerve for pain and temperature descend to the level of the upper cervical spinal cord before they synapse with neurons of the nucleus of the descending tract of the fifth nerve. Second-order neurons then cross over and ascend to the VPM of the thalamus. The motor portion of this nerve is examined by testing the masseter and the pterygoid muscles. The sensory portion of this nerve is tested with light touch and pinprick in the 3 sensory divisions of the nerve, the ophthalmic, maxillary, and the mandibular division. Cranial nerve number 7. This cranial nerve has a motor component for muscles of facial expression, parasympathetics for tear and salivary glands, and sensory for taste for the anterior 2/3 of the tongue. For a lesion of the 7th nerve, which is commonly called the Bell's palsy, it is important for anatomical localization to test all the components of the 7th nerve: muscles of facial expression, taste, the muscles of the stapedius, as well as lacrimation. It's important to realize that for a peripheral or lower motor 7th nerve lesion, all the muscles ipsilateral to the affected nerve will be weak. Whereas in the central or upper motor neuron lesion, only the muscles of the lower half of the face, contralateral to the lesion, will be weak because of the portion of the 7th nerve nucleus that supplies the upper face receives bilateral cortical bulbar or upper motor neuron input. Cranial nerve number 8. This nerve is a sensory nerve with 2 major divisions, acoustic and vestibular. The acoustic division is tested by checking auditory acuity and with the Rene and Weber test. A neurologically caused unilateral hearing loss is almost always localized to the sensory organ, the spiral ganglion, nerve, or cochlear nucleus. There is such extensive bilateral projection from the cochlear nuclei to the auditory cortex that lesions above the cochlear nucleus seldom cause unilateral hearing loss. The vestibular division of this nerve is important for balance. Clinically, it can be tested with the oculocephalic reflex and the oculovestibular reflex. Cranial nerves 9, 10, 11, and 12 are located in the medulla and have localizing value for lesions in the most caudal part of the brainstem. Cranial nerves 9 and 10. These 2 nerves are clinically lumped together. Motor-wise, they innervate pharyngeal and laryngeal muscles. Their sensory component is sensation for the pharynx and taste for the posterior 1/3 of the tongue. In clinically assessing 9 and 10 function, it's important to test both voluntary and non-voluntary or reflex activity. Voluntary action can be observed as the patient says ah or ka. Non-voluntary or reflex action is observed with the gag reflex, which is both a sensory and a motor limb to the reflex. Patients with bilateral lower motor neuron lesions have both absent voluntary and reflex activity. Patients with bilateral upper motor neuron weakness or dysfunction will lack voluntary movement of the palate, but will have the reflex gag or even a hyperactive gag reflex, just like a hyperactive deep tendon reflex with upper motor neuron disease. This is how a bulbar or a lower motor neuron palsy is sorted out from a pseudobulbar or an upper motor neuron palsy. For upper motor neuron disease to cause palatal weakness, it must be bilateral because there's bilateral upper motor neuron innervation for each of the nuclei ambiguous. Unilateral lower motor neuron or nerve weakness causes less elevation of the palate on the side of the lesion with deviation of the uvula to the high arched normal side. Cranial nerve 11. This nerve is a motor nerve for the sternocleidomastoid and trapezius muscles. The upper motor neuron control for the sternocleidomastoid muscle is an exception to the rule of the ipsilateral cerebral hemisphere controlling the movement of the contralateral side of the body. Because of the crossing then recrossing of the cortico-bulbar tracts at the high cervical level, the ipsilateral cerebral hemisphere controls the ipsilateral sternocleidomastoid muscle. This makes sense as far as coordinating head movement with body movement if you think about it. Remember that the sternocleidomastoid muscle turns the head to the opposite side. So if I want to work with the left side of my body, I would want to turn my head to the left, so the right sternocleidomastoid muscle would be activated. Cranial nerve 12. The last of the cranial nerves, number 12, supplies motor innervation for the tongue. For lower motor neuron weakness, the tongue deviates towards the side of the lesion. Bilateral upper motor neuron lesions cause a pseudobulbar palsy of the tongue, manifested by slow and incomplete tongue movements, especially on the side-to-side movement. Traps. A sixth nerve palsy may be a false localizing sign. The reason for this is that it has the longest intracranial route of all the intracranial nerves. Therefore, it is the most susceptible to pressure that can occur with any cause of increased intracranial pressure. Pearls. Rules of diplopia. Number 1, diplopia is maximum in the direction of action of the paretic muscle. Number 2, the most peripherally seen image is the false image and comes from the eye with the paretic muscle. Number 3, diplopia is horizontal if the medial and lateral recti are involved and vertical if the levator or depressor muscles are involved. Internuclear ophthalmoplegia. A lesion of the medial longitudinal fasciculus causes nystagmus of the abducting eye with absent adduction of the other eye. The lesion is on the side of the non-adducting eye, or the eye that does not adduct. There can be bilateral internuclear ophthalmoplegia, in which case neither eye adducts on range of motion.